Hey everyone, and welcome to the Deep Dive.
I'm Donna.
I'm Harvey. We're both MCCQE reviewers, and we know just how much work goes into getting ready for this exam.
Yeah, it can be pretty intense.
So we're here to make it a little easier and help you feel more confident about those tricky pharmacology topics that you're going to see on the MCCQE.
We're breaking it all down for you in this deep dive.
We're focusing on 4 important drug classes today: beta blockers, calcium channel blockers, nitrates, and muscarinic antagonists.
And don't worry, we're not just making this up. We're using evidence-based sources like stat pearls.
Absolutely.
Wow.
But before we jump in, a quick disclaimer. This is for educational purposes only. It's not medical advice. So always talk to a qualified healthcare provider for any health concerns.
Couldn't agree more.
All right, ready to dive in?
Yeah, let's go.
Ah.
Okay, so first up, beta blockers. Did you know that some performers and athletes actually use beta blockers to help with stage fright? Yeah, it's true. It might seem a little strange, but it all comes down to how beta blockers work on the body's fight or flight response. You know that feeling when you're about to give a big presentation or perform in front of a crowd?
Oh yeah, I've definitely been there.
Yeah.
Your heart starts racing, palms get sweaty, maybe you even feel a little shaky.
Exactly. That's your sympathetic nervous system kicking into gear. It's releasing hormones like adrenaline and noradrenaline, which bind to beta receptors all over your body, especially in your heart and blood vessels.
So those beta receptors are what cause all those physical symptoms.
Yeah. The increased heart rate, the rise in blood pressure, all of that comes from those hormones binding to those receptors.
Okay, so beta blockers essentially block those hormones from attaching to those receptors.
Precisely. They stop them from binding, which in turn reduces the effects of adrenaline and noradrenaline. So your heart rate slows down, your blood pressure goes down, and you feel less anxious overall.
That makes sense.
Yeah.
But how does that actually help treat serious conditions like hypertension and heart failure?
Well, with hypertension, high blood pressure, the force of blood constantly pushing against your artery walls can cause damage over time. Beta blockers, by slowing down the heart rate and reducing the force of those heart contractions, help lower blood pressure and reduce that strain on your arteries.
And for heart failure, where the heart isn't pumping as efficiently as it should.
In heart failure, the heart's working overtime, struggling to keep up with the body's demands. Beta blockers actually help by easing the workload on the heart, which improves its pumping ability and can slow down the progression of the disease.
It's interesting that slowing down the heart actually helps it work better.
Yeah, it seems a little counterintuitive, but it's true. Now, it's important to note that not all beta blockers are the same. There are selective and non-selective beta blockers, and understanding the difference is crucial.
Right, I vaguely remember that. Something about different types of beta receptors.
Exactly. Beta 1 receptors are mostly found in the heart, while beta 2 receptors are located elsewhere in the body, like the lungs.
So selective beta blockers target the ones in the heart.
Exactly. Like atenolol or metoprolol, they mainly act on the heart and are less likely to affect other organs like the lungs.
So that's why they're safer for someone with asthma.
Exactly, because non-selective beta blockers like propranolol block both beta 1 and beta 2 receptors. Blocking those beta 2 receptors in the lungs can make breathing harder for someone with asthma.
That's a great example of why it's so important to understand those receptor subtypes when you're choosing the right medication.
Absolutely. It's not just about knowing the drug class, it's about understanding how those nuances affect different patients.
Okay, so we know they lower heart rate and blood pressure, but what about side effects? You probably know the common ones like slower heart rate, maybe some fatigue.
Right. But are there any side effects that people might not expect?
Yeah, definitely. Some people experience sleep disturbances like insomnia or vivid dreams. It's not super common, but it's something to be aware of.
That's interesting. I hadn't heard that one before.
Another one that's really important, especially for diabetic patients, is that beta blockers can actually mask the symptoms of hypoglycemia. Hypoglycemia, that's low blood sugar.
Exactly. Usually when your blood sugar drops, your body releases adrenaline, which causes symptoms like a rapid heartbeat, trembling, and sweating. But because beta blockers block those adrenaline effects, those symptoms might be less noticeable.
So people might not realize their blood sugar is low.
That's the danger. It's
Yeah.
really important for patients to be aware of that. Okay, before we move on, there's one more beta blocker I wanted to talk about, sotalol. It's unique because it has this extra mechanism of action.
Oh, yeah. I remember hearing about that one. What's so special about it?
Well, in addition to blocking beta receptors, sotalol also blocks potassium channels in the heart. This gives it an added effect of regulating heart rhythm, which is why it's sometimes used to treat arrhythmias.
Interesting. So it's kind of like a 2-for-1 drug.
Yeah, you could say that. But it's important to note that because of that dual action, sotalol can also increase the risk of a specific heart rhythm problem, called torsades de pointe.
So it's a drug that needs to be used cautiously.
Absolutely. Okay, ready to move on to calcium channel blockers.
Let's do it. This one's a little scary. I read somewhere that calcium channel blockers are a leading cause of drug-related deaths.
Yeah, I've seen those statistics too, but it's important to remember that context. Most of those deaths happen from overdoses. Calcium channel blockers are still really important medications, especially for treating hypertension, angina, and certain arrhythmias.
So it comes down to using them correctly and monitoring patients carefully.
Exactly. Now, to understand how calcium channel blockers work, we need to think about calcium's role in the body. Calcium's essential for muscle contraction, including the muscles in our heart and blood vessels.
So blocking calcium channels would essentially relax those muscles.
You got it. They prevent calcium from entering muscle cells, which leads to relaxation.
Okay. And in the context of hypertension, that relaxation of blood vessels helps lower blood pressure.
Right. And with angina, it helps by reducing the heart's workload, which eases chest pain because the heart needs less oxygen.
I see. But I remember learning about different types of calcium channel blockers.
Absolutely. There are dihydropyridines like amlodipine and ivabepindine. They mainly act on the blood vessels as vasodilators.
And the other type.
Those are the non-dihydropyridines like verapamil and diltiazem. They have a greater effect on the heart itself. They slow down the heart rate and reduce contractility, which is the force of the heart's contractions.
So you choose the type of calcium channel blocker based on what you're treating.
Precisely. And that's where knowing the specifics of each medication becomes really important. For example, if someone has both hypertension and a fast heart rate, a non-dihydropyridine might be a good choice because it addresses both issues.
Sounds like a lot of factors to consider.
Definitely. And on top of that, you also need to be aware of potential drug interactions. That's where pharmacists play a crucial role. They're experts at spotting potential interactions that could be harmful.
Right. So if someone's already taking multiple medications, the pharmacist can help make sure the calcium channel blocker won't cause any problems.
Exactly. Now, what about those side effects? With dihydropyridines, because they relax blood vessels, you might see things like headaches, flushing, or ankle swelling.
That makes sense.
Yeah.
What about the non-dihydropyridines?
Constipation's a common complaint. And because they act on the heart, there's a risk of bradycardia, a slow heart rate, and even heart block, particularly in patients with pre-existing heart conditions.
It seems like those side effects directly relate to how the drugs work in the body.
Yeah, it's all connected. Okay, so we've covered beta blockers and calcium channel blockers. What do you say we move on to nitrates?
Let's do it. I've always found nitrates really interesting. Maybe it's because they have such a long history.
You're right. Nitrates have a long and pretty fascinating history. Did you know they've been used to treat chest pain for over 170 years?
Wow, seriously. That's even longer than I thought. How did they even figure that out back then?
It all started with nitroglycerin. Back in the 1800s, workers in dynamite factories noticed that handling nitroglycerin gave them headaches and dilated their blood vessels.
Wait a minute, are we talking about the same nitroglycerin that's in dynamite?
The one and only. It's pretty remarkable, right? Doctors at the time put two and two together and figured that if nitroglycerin could dilate blood vessels, it might help treat angina, which is chest pain caused by reduced blood flow to the heart.
That's amazing. Talk about an accidental discovery. So how does nitroglycerin actually work to relieve that chest pain?
Okay, so nitrates like nitroglycerin convert into nitric oxide in the body.
Nitric oxide.
Yep. And nitric oxide is a powerful vasodilator. It relaxes and widens those blood vessels.
And that's important for angina because
angina is caused by narrowed coronary arteries, the blood vessels that supply the heart muscle. By dilating those arteries, nitrates increase blood flow to the heart, which relieves the pain.
So it's like clearing a traffic jam on the highway, letting all that blood flow freely to the heart.
Exactly. And speaking of different ways to get nitrates into the system, there are a lot of different forms, from those sublingual tablets that you put under your tongue for fast absorption to long-acting patches that release the medication slowly over time.
So doctors have options for whether they want immediate pain relief or to prevent angina episodes from happening.
Exactly. Which brings us to another important point. Nitrate tolerance.
Nitrate tolerance. I haven't heard of that. What is it?
It's basically when your body gets used to nitrates after being exposed to them for a while and they start to become less effective.
Oh, so they stop working as well.
Yeah, it can be a problem, but there are ways to prevent it. A common approach is to have nitrate-free periods, usually at night. This gives the body a chance to reset and regain its sensitivity to the medication.
So it's all about giving the body a break from the nitrates so they can keep working.
Exactly. Okay, so we've covered a lot of ground with nitrates. Ready to tackle our last drug class for today? Muscarinic antagonists.
Let's do it. I'm ready.
Man.
What are we diving into with this one?
Well, I think this is a good way to wrap up our deep dive today because it brings us back to the nervous system and how different drugs target different parts of it.
Okay. I'm intrigued.
Tell me more. So we've talked a lot about the sympathetic nervous system and the fight or flight response.
Right. That's the one that gets us all amped up.
Exactly. But muscarinic antagonists act on the opposite side of the nervous system. The parasympathetic nervous system, which is responsible for the rest and digest functions.
Oh, yeah. I remember that one. It's all about slowing things down and helping us relax.
Precisely. Now, the parasympathetic nervous system uses a neurotransmitter called acetylcholine, which binds to muscarinic receptors throughout the body.
And these receptors are involved in.
Lots of things, from slowing down the heart rate to increasing digestion and constricting the airways.
Okay. And muscarinic antagonists block these effects.
Yep. By blocking acetylcholine from binding to those muscarinic receptors, they can have a variety of effects depending on which receptors they target.
Sounds like a pretty versatile class of drugs.
Yeah.
So what are some examples of how they're used?
One you'll definitely want to know is epitropium. It's commonly used to treat COPD,
COPD.
chronic obstructive pulmonary disease. It's a condition where the airways are narrowed, making it hard to breathe. Epitropium works by relaxing those muscles around the airways and making breathing easier.
Ah, so it's a bronchodilator.
Exactly. And aside from COPD, it can also be used for things like asthma and rhinitis.
Pretty handy.
Mm.
Now, I also remember reading about another muscarinic antagonist, atropine, that's used for something pretty serious, organophosphate poisoning.
That's right. Organophosphates are found in some pesticides and nerve agents. They cause this dangerous buildup of acetylcholine in the body.
And what does that do?
It leads to all sorts of problems, like a slowed heart rate, difficulty breathing, and even paralysis.
That sounds terrifying.
It can be. But atropine can be a lifesaver in these situations. It blocks that excess acetylcholine and reverses a lot of the effects of the poisoning.
So it's the antidote.
Pretty much. But it's important to remember that the dosage and timing are crucial with atropine. Too much or too late can have serious consequences.
So it's a delicate balance. Well, I think we've covered a ton of information today.
It's been a whirlwind tour of pharmacology. We've talked about mechanisms of action, clinical uses, side effects, and even some interesting historical facts.
My brain is definitely full.
I know it's a lot to take in, but hopefully you're feeling a little more confident about these drug classes now.
I definitely am. But to be honest, I'm feeling a little overwhelmed too. There's just so much information.
I hear you. Pharmacology is a huge subject, but the key is to take it one step at a time and focus on understanding the basic concepts. You don't need to memorize everything at once.
Good point. So what should we focus on next?
Let's take a few minutes to go back over the key points we've talked about today. Repetition is really helpful when it comes to learning pharmacology, and reviewing these core concepts will help you remember everything.
Okay, great idea. Let's do it.
Okay, so let's do a quick recap of those 4 drug classes. We'll start with beta blockers. What are the key things you remember?
Okay, so beta blockers, they basically block the effects of adrenaline and noradrenaline.
Right.
And that leads to like a slower heart rate, lower blood pressure, and less strain on the heart.
Yeah.
Which is why they're so effective in treating hypertension and heart failure.
You got it. You've hit the nail on the head. And remember, we talked about selective versus non-selective beta blockers.
Yeah, selective ones, they target those beta-1 receptors in the heart.
Mm-hmm.
So they're a safer choice for patients with asthma because they're less likely to affect their breathing.
Exactly. And then the non-selective beta blockers, those block both beta-1 and beta-2 receptors. So those could potentially worsen breathing problems for those asthma patients.
Right. Makes sense. Okay, what about calcium channel blockers? What do you think is important to remember about those?
Well, what stands out to you?
I think the most important thing is to remember that there are 2 main types, the dihydropyridines and the non-dihydropyridines. They each have a different way of working.
Okay, go on.
So the dihydropyridines, like amlodipine, those mainly work on the blood vessels, causing vasodilation, which makes them great for lowering blood pressure.
Absolutely. What about the non-dihydropyridines?
Those are the ones like verapamil. They have more of an effect on the heart itself. So they slow down the heart rate and reduce contractility.
Right. And that makes them useful for
For treating certain types of arrhythmias.
Perfect. And remember we talked about how calcium channel blockers can interact with other medications?
Yeah, pharmacists definitely play a big role there.
Yeah.
They can make sure there aren't any dangerous combinations.
Exactly. Okay, next up, nitrates. You mentioned earlier, they've been used for over 170 years to treat chest pain. It's pretty amazing.
I know, right? I still can't get over that dynamite connection.
It's a pretty cool bit of medical history. So
Yeah.
just to recap, the key thing with nitrates is that they convert into nitric oxide in the body.
And nitric oxide is.
It's a powerful vasodilator. It relaxes and widens those blood vessels, which increases blood flow to the heart muscle and relieves that chest pain.
Right. And there are all those different forms of nitrates, too, like the sublingual tablets and the long-acting patches.
Yep, doctors have options depending on whether they need quick relief or if they want to prevent angina episodes.
But remember, if you use them continuously for too long, you can get that nitrate tolerance.
Right, so those nitrate-free periods are important to help the body regain sensitivity to the medication.
Makes sense.
Yeah.
Okay, last but not least, we've got the muscarinic antagonists. What's the main takeaway here?
Well, for me, what's really interesting is that they work on the parasympathetic nervous system. So that's the rest and digest side, which is almost the opposite of what the beta blockers do.
Right, so they're all about slowing things down.
Exactly. And they do that by blocking the effects of acetylcholine. That's a neurotransmitter that's super important for the parasympathetic nervous system.
And remember, we talked about how ipratropium, a muscarinic antagonist, is used to treat COPD.
Yep. It relaxes those airways, making it easier to breathe.
And then there's atropine, which is used for organophosphate poisoning.
Right. Atropine can be a real lifesaver in those cases.
Wow. We've covered a lot of ground today.
We have. It's been a pretty intense deep dive into pharmacology. But hopefully you're starting to feel more comfortable with these drug classes now.
I definitely am. But I have to admit, I am feeling a little overwhelmed. It's a lot to process.
I know. It's a huge topic. But the good news is you don't need to memorize everything. You just need to understand the core concepts and how to apply them.
So it's more about understanding the big picture than memorizing every single detail.
Exactly. And one of the best ways to do that is to think about how this knowledge applies to real-life situations. Think about the types of patients you might see and how you would use this information to help them.
That's a great point. So how can we use all of this to prepare for the MCCQE?
Well, the MCCQE is all about testing your ability to apply your knowledge to clinical scenarios. So one of the best things you can do is practice answering practice questions. Pay attention to how the questions are worded and the situations they present.
So it's not just about knowing the facts, it's about knowing how to use them.
Exactly. Another helpful thing you can do is create your own study aids like flashcards or concept maps. Anything that helps you organize the information and make connections between different concepts.
Those are great tips. I'm definitely going to try that.
And one last thing I'd emphasize is to stay calm and focused during the exam itself. It's easy to get stressed out, but just remember to breathe, read the questions carefully, and trust in your preparation.
Great advice.
Yeah.
It's easy to get overwhelmed when you're in the exam room, but it's important to stay grounded.
You've got this.
Yeah.
And remember, we're here to help you along the way. So if you have any questions about anything we've talked about, don't hesitate to reach out.
Definitely. We're always here to support our listeners.
Okay, I think it's time to wrap things up. So what's our final thought-provoking question for today?
Let's see. I think it would be interesting for our listeners to think about the future of drug development. We've talked about how medications target specific receptors in the body.
Right. But what do you think the future holds? With all the advances in medical research, will we see even more targeted therapies that can really zero in on the root cause of a disease? That's a really great question. And it's something that researchers are working on right now. The field of pharmacology is constantly evolving. So I have no doubt that we'll see some groundbreaking discoveries that will change how we treat diseases. Imagine medications that are tailored to your specific genetic makeup.
Wow, that's amazing.
It is. It's exciting to think about all the possibilities. And I believe that by embracing innovation and pushing the boundaries of science, we can create a healthier future for everyone.
That's a great note to end on. It's pretty incredible when you think about all the advances we've made in medicine.
It really is. And it all comes back to understanding the fundamentals like what we've been talking about today.
Exactly. We've covered those 4 key drug classes: beta blockers, calcium channel blockers, nitrates, and muscarinic antagonists. We talked about their mechanisms, their uses, side effects, even a little bit of history.
It's been a pretty thorough journey through the world of pharmacology.
Definitely. And what really stood out to me? How much we emphasize the why behind these medications.
It's not enough to just memorize names and dosages, right?
Right. We have to understand how they work in the body, how they interact with different systems, and how that all translates to what we see in our patients.
Absolutely. It's like learning a new language. You need to understand the grammar and vocabulary before you can really speak it.
That's a great analogy. And just like learning a new language, it takes time and effort and practice.
It does, but it's worth it in the end. When we understand the why, we can make better decisions for our patients and provide safer and more effective care.
Absolutely. And for all our listeners out there who are studying for the MCCQE, remember, this is just the beginning of your pharmacology journey.
There's still a lot to learn, but if you focus on those core concepts and practice applying them to clinical scenarios, you'll be well on your way.
And remember, we're always here to support you. So keep learning, keep asking questions, and most importantly, believe in yourselves.
You got this.
All our future doctors out there, we're cheering you on.
Until next time, stay curious and never stop learning.
And that's a wrap on another episode of The Deep Dive. We'll see you next time.